It's day 2 of the American College of Cardiology 2011 meeting and the I2 Summit in New Orleans. The convention center is packed with attendees who are absorbing the latest cutting-edge research. And we're going to be bringing you all the breaking news coverage starting now. Welcome to CardioSource Video News. I'm Dr. Randy Martin. There is a sense of excitement here at the convention center in New Orleans as cardiovascular specialists from around the world share and learn the latest scientific findings. Investigators are releasing several key late-breaking clinical trials this morning, and to help us evaluate the information, we've assembled a fabulous group of colleagues. Our expert panel includes Dr. Peter Block. Peter is professor of medicine and the director of the structural heart program at the Emory University Hospital in Atlanta, Georgia. Dr. Athena Pappas is associate professor of medicine at the Brown Medical School and the Rhode Island Hospital. And Dr. Tony DeMaria is professor of medicine at the University of California in San Diego and editor-in-chief of the Journal of the American College of Cardiology. I'm glad to be joined by all of them. And before we get started on some of the trials, there was a very interesting report about antidepressants being associated with accelerated atherosclerosis. Any antidepressant. Tony, what's your take on this?
Well, my take on this was that it was a great deal about nothing. It's a classic surrogate endpoint, and intimomedial thickening, as judged by a paper we recently published in JACC, really has not borne good reliability in terms of predicting endpoints. So I think we have to take this 37 micron
37
difference.
to 41 micron difference.
So a surrogate endpoint, I wouldn't put too much faith in these findings.
One of the popular press said that that meant that somebody had, it was a twin study. That means one of the twins had 4 years of accelerated age. I mean, you can't take that, can you? Can you say that?
All my brothers are older than me anyway.
So you think that the endpoint was a limitation?
I think it was a surrogate endpoint and the changes were minimal, and that particular surrogate endpoint has not been found to be predictive of events.
Okay, good. Let's move on to what else. What's late breaking? Peter, what do you look? There's some neat stuff.
Well, there is some neat stuff. The EVEREST II trial is an important trial. The EVEREST II trial is the mitral clip against surgery, and we've known about the EVEREST II trial for now a year and a half or 2 years. The one-year results showed that there was a difference initially between surgery and the clip, no question. At 90 days, there was a significant difference in the way the two groups fleshed out. But then at 90 days, they started, the lines of mortality and endpoints actually became parallel. And the question is, will that keep up? Because the surgeons have always said the clip is not going to last because we always put a ring in when we do anything else with a mitral valve. We can't put a ring in percutaneously. So the answer is at 2 years now, it looks like those lines are still parallel, which is important. And the clip seems to be holding up, and some of those patients have gone out to 3 years. Optimistic for now, and maybe for an elderly patient, they don't have to go out 10 or 15 years. Maybe 4 or 5 years will be enough. So we'll see how that goes forward, but for now, optimistic.
Athena, what do you think?
Well, I think one part of mitral regurgitation is there's organic and then there's functional. And I think a small percentage, 20% or so, were functional. And that's really the tricky population. And that's the population where you'd wonder about a ring long-term holding up. Conversely, having some non-surgical options for that group. So I think we'd like to see more about that subgroup in particular.
That's going to be the next study, I think, as to whether or not patients who have congestive heart failure and secondary MR from functional mitral regurgitation will in fact be helped by the clip.
Perfect.
In Europe, they seem to be helped by the clip. Interesting.
Tony?
And the procedure is evolving. I sent a patient recently, and he came back with 2 clips, they told me that as time has gone on, they've used more and more clips. So I think it's a moving target, and it is encouraging that at least at 2 years, it seems to be holding up.
Good. Other trials that are breaking this morning. Athena?
I think the STICH trial is really exciting because, one, it's taken a long time to get this data out, and we finally have good data that it looks like surgery, at least for cardiovascular mortality, is superior to medical management in this group of patients with low ejection fractions and multivessel disease. Interestingly, a few caveats of it, the patients couldn't have class 3 or 4 angina, so not that sick as far as ischemia. Very nice that they had a about 30% African Americans included.
Right.
So good to see that as well. So I think we're seeing some interesting, finally, data comparing medicine and surgery. And the last piece that worries me a little bit is only a small percentage of patients had ICDs. So again, part of the problem with studies started 10 years ago is we evolved so quickly.
The evolving practice. Comments on this part of the
I
STICH?
must admit, I had perhaps just a slightly different take than Athena. I looked at the front end mortality with surgery, which was formidable, and then looked at the endpoint. And if you look at the primary endpoint, which was all-cause mortality, there was no difference. So I would find it of little consolation that I didn't die of cardiovascular disease, but I died anyway. So for me, if I was a patient in these settings, I'd have to think long and hard about undergoing surgery in that situation.
Peter, before we go to break, quick comments.
Yeah, well, there's another part of STICH that I think is fascinating, and that is in patients who had viability studies, whether they went to surgery or medicine, the fact that they had viability studies and seemed to be better candidates made no difference at all. We may be doing too many viability studies in patients that we send to surgery.
Okay. Athena?
I think, again, most of the viability was done with SPECT and dobutamine echo, again, reflecting that it's a slightly older study and not that it would be repeated now, but PET and MRI has better sensitivity, which is what we want to know.
Okay, we're going to pick this up and just finish it in a minute, but we're going to take a short break. We'll be right back.
You're watching CardioSource video news coverage of ACC.11 and I2 Summit 2011.
Meet Maria, proud grandmother. She complains that her heart beats strangely, and she's just had an aortic valve replaced. Maria wants to be well so she can be with her grandchildren. Follow Maria's journey from admissions to treatment and release from the hospital setting, and then to post-release care, with all the steps along the way aimed at reducing her chance of being readmitted. Experience the hospital-to-home learning destination, Hall D, number 3347, to learn about innovative technologies and solutions aimed at reducing hospital readmissions. Plus, hear from leading experts in the field and learn how they are implementing new processes to reduce readmissions in the H2H theater.
Well, immediately what we noticed is patients telling us that they really preferred the radial approach. When we first started doing this, they came to us expecting that we would be doing this via the femoral approach. They came expecting a prolonged bed rest time. They even warned us. They said, look, I've got a lot of back problems. I'm going to have trouble laying flat. And when we started doing it from the wrist and they were able to get up and ambulate right away, they were really thrilled.
Welcome back to CardioSource Video News. I'm joined again by Doctors Block, Pappas, and DeMaria, the fabulous law firm here in New Orleans, it sounds like. Now, before we went to break, we were talking about the viability aspect of the STICH trial, and Athena made some points. Tony, you were going to jump in.
No, I think the points are really valid. In this day and age, delayed enhancement by MRI plays a really important role, PET scanning, of course, so that we have to be careful. The other issue is viability is one part, but ischemia is another, and we really don't yet have an answer that if the patient has ischemia, whether or not they benefit by revascularization.
Okay, good. Peter, some more interesting trials came out.
Yeah, there's another trial about the Impella versus intra-aortic balloon pump for high-risk angioplasty called PROTECT. And it's an issue that's been around for a number of years in interventional cardiology. Should we or should we not protect patients that we think are going to crash? And this is a trial that finally tried to answer that. It's a funny trial, and I'm not sure what to make of it, because it was stopped early because they could not reach their primary endpoint. And yet, when they looked at 90 days versus 30 days, there was a p-value that became significant in patients that had atherectomy, mostly rotoblator. Now, I don't know what to make of that, very candidly. My guess is, if it were me, I would say, I think we need more data before we can really say one way or another whether the Impella truly is better than the intra-aortic balloon pump. And for now, the other question is, do you really need a device to get a patient through a high-risk angioplasty? And we don't know that answer for sure.
So you think this is not going to impact practice right now?
I think for now, people will look at it carefully, but wonder what the right thing is to do.
Athena, you want to jump in on this?
Well,
or do you
I'm
want to
just curious. So tomorrow, if you have a high-risk intervention, Peter, are you going to get out an Impella, or are you going to get out a balloon pump, or neither?
I probably am going to run for it and do neither, but if I need to, I'll probably still go with an intra-aortic balloon pump.
Okay.
Yeah. Okay. What about other trials? PRECOMBAT?
Well, PRECOMBAT's interesting, and it looked at left main stenting versus cabbage, drug-eluting stents, obviously, for left main. And it was a non-inferiority trial. They didn't reach their primary major adverse cardiovascular events combined endpoint at 1 year, so they went out to 2 years and did show non-inferiority at that point. So interesting. I don't know that it's going to make a big change. Maybe not enough data yet.
Tony,
Well,
you want to tell me how you really think? So,
well, you know, Randy, I've really been impressed with the trials at this meeting, that there's been a lot of statistical manipulation. You looked at adjusted hazard rates, you looked at non-inferiority and surrogate endpoints, and it reminds me of that old Will Rogers statement that facts are hard things, but statistics are more pliable. And I think we're seeing that increasingly in these trials, and it's hard to take home a firm message from them when they're couched in so much statistical analysis.
so go ahead.
No, I think you're right, but the issue here is the big questions. We've really got our hands around the big questions, and I think what we're seeing is a lot of trials that are starting to ask questions about the smaller issues which have fewer endpoints, and it's more difficult to make the statistics come out right if you have not very many endpoints coming at you in a trial. So that may be part of what's causing this, Tony.
Sure.
Go ahead.
Well, I think, in this trial, for example, the PCI still had more adverse events, but it still was not inferior by the 7% margin they set. So if you're the patient, I don't know that that gives you the confidence to choose the other study.
I mean, left main stenting and complete occlusions are the hottest things going in interventional cardiology. So what's the message what's the message out of this PRECOMBAT?
Well, I think the message is if you had a left main stenosis and it were in the body of the left main, Syntax showed us that you can do a stent and do very well as long as your peripheral disease in your distal coronary arteries is not major. And I think that still holds. And this supports that. It simply says if you put a sirolimus-eluting stent in a left main stenosis, you can do okay.
Yeah, I think, Peter, at least in my area, the majority of left main patients are still going to surgery, and I think that's been the mindset. And I suspect studies like PRECOMBAT are going to hammer home the message that intervention is a viable alternative, particularly, as you mentioned, for the mid-left main lesion.
Okay. We'll sort of wrap up. Let's go through any other trials or anything that's happened to date in the meeting that strikes you. Athena, we'll start with you. And thank you. We'll go next.
I was going to have the same answer.
Your coffee's been very good.
And finally, we'll go to Dr. Here you have the geriatric panel trying to think. So are there other things that have gone on that strike your fancy? And hard to say. This is when we go to a commercial, isn't that right?
Yeah.
Tony, you did the Bishop yesterday. It was fabulous.
That's great.
You got a lot of response. What was your message in that?
Well, the message is in trying to balance between clinical judgment and trial data. I think the pendulum really has swung over, and it's overswung to clinical trial data, and people need to recognize, as we pointed out in this panel, that there's a lot of limitations to clinical trial data when you apply it to an individual patient. And in fact, clinical judgment is really important in doing that.
All right, so that's the bottom line. That's what your take-home message is. Be sure and check back with CardioSource Video News throughout the day, as we're going to be bringing you the latest in-depth findings that could impact your practice. I'm Dr. Randy Martin, and thanks for joining us.